they try.
Good afternoon, ladies and gentlemen.
Good afternoon, sir.
Hello, can you all hear me? Can you hear me?
Hey, Mama. Yeah, we can hear you. Hey.
Okay. My name is Pharmacist Victor Obunda, and on behalf of the Superior Pharmaceutical Care, I want to especially welcome everyone in the room to this meeting. And in this meeting, we'll be looking at the management of BPH in a primary care environment by general practitioners. We want to ask, why this meeting? With the rising cases of the BPH, which seems to be outpacing the capacity of available specialists, this webinar aims to equip general practitioners with the knowledge and skills necessary to manage BPH. We have in our midst Prof Jeje Urologist at the College of Medicine, University of Lagos. Prof will be taking us through this topic, and we take us with questions and comments. End of his presentations. So welcome, Prof.
You're Ali. Wait, no, Mama, I can't imagine. Go.
Hello, Prof. Here.
Good afternoon, Victor. Can you hear me? Victor, can you hear me?
Hello, can you hear me?
Yes, I can hear you. Can you hear
Hello?
me? Yes. Can you hear
Hello,
me?
can anybody hear me in the house?
We can hear you, sir. We can hear both of you, sir.
Okay.
Hello?
Yes, I can hear you, and I'm told that they can hear me too. Can I start?
Yes, sir.
Can you hear me now?
NSM, we can hear you. We can all hear you.
Okay.
You can
Okay,
start.
Okay, we can start. Okay. My name is Pharmacist Victor Obunda. And on behalf of Superior Pharmaceutical Limited, I want to especially welcome everyone in the room to this special meeting. And in this meeting, we'll be looking at the management of BPH in a primary care environment by general practitioners. And like I said, one may want to wonder what informs this meeting. Why this meeting? With the rising cases of BPH, seems to be outpacing the capacity of available specialists. This webinar aims to equip general practitioners with the knowledge and skills necessary to manage BPH effectively. And to lead this important discussion, we will have in our midst Professor Prof Jeje. Prof is a consultant urologist at the College of Medicine, University of Lagos, and he will be taking us through this topic. We will also going to be taking questions and comments at the end of his presentation. Let us welcome Prof. Prof, you have the floor. You are welcome, sir.
Okay. Let me say good afternoon to everyone. And I want to first of all find out, can you all see my slide?
Yes, you can. At least I can from my own end.
Okay. Okay. Once again, let me thank the organizers of this short talk on management of BPH by GPs or general practitioners or physicians in the primary care environment. I know one of the reasons why they are supporting this talk is to promote their pharmaceutical drugs, which is called Flowell. And I usually make jest of them that they choose a good name that will sell among our patients. So that's why I put up this slide. Let it flow, and let it flow well. I guess they borrowed that dictum from the Japanese company, Yamasuchi, that actually own the Tamsulosin product. They called it, when it came to the market, Flomax. That's a way in which to be able to catch up patients' mentality towards the drug. Before I go ahead, let me declare, I don't have any interest in Superior Pharmaceutical. In fact, I don't have any share in any pharmaceutical company. Rather, I have a few pharmaceutical companies who have share in my business. So there's no conflict of interest. The only thing I do is promote medications that can help our patients. And this topic is so important in the sense that we are both caregivers. You, my colleagues at the primary setting, and those of us in the teaching hospitals or in tertiary centers. And we see a lot of these patients, a lot of them, lots and lots of them, coming around. Some of them will have even been at loose at 5 a.m. and I probably will not be able to see them until midday. And all I need to do is to refill their drugs. And somehow one feels a little bit uncomfortable when you look at the time frame that some of these patients had to cope with, only for me to write drugs and manage them when I'm so sure that they can as well be well managed by their primary caregivers. So it is obvious that we need to collaborate. It's obvious that we need to talk a lot, interaction between us and the primary caregivers. You, our colleagues, they are very close to the patient. Because with an increasing age, more and more people are living longer. And a lot more people are taking care of themselves, realizing that they need to be of good health. So with an increasing age, you find out that more and more people will be presenting to you as general practitioners or the physicians, primary physicians that are in their locality, very close to them, with lower urinary symptoms, which is basically most often due to prostate enlargement. So your workload as regards urology will increase as the age of our population increases. In fact, it's believed that by this year, 2025, more than 50% of people in Europe will probably be 50 and above because of the age pyramid in that society, because they live long. And that is also happening now. We now find more and more people. I'm sure if you do the life expectancy now in Nigeria, it will not be the issue of 48 for men or 52 for women. So it's an important thing that general practitioners should familiarize themselves with the fact that a lot of these men will present with symptoms of urethral symptoms, either directly or indirectly. Indirectly, when you come around with medical checkups or things like that, and you should know what we need to do for them. So let's briefly just look at what are these things that we need to know when these patients come to us. What is the prostate? It's just to remind ourselves, I'm sure we all remember what the prostate is. It's a small gland that is regarded as a walnut. But I say I used to call it as a kola nut with 2 or 3 lobes, which is at the base of the bladder. That erupts the prostatic urethra and is extremely important for the male. And I used to say that without the prostate, which not only is stored and secreting about 30% of what constitutes the seminal fluid, is extremely important for a man, for him to be able to father a child by natural means. I always say that without the prostate, a gentleman cannot father a child by natural means. Remember where it is located. Look at this slide. It's just there. And it's just at the outlet of the bladder. Posteriorly is the rectum. And that's why it's so important that we can feel the prostate during a digital rectal examination, because it has a very related relationship to the rectum. I'm sure we all remember in our schools in those days, in the Bailey and Love, that one of the tenets of assessing the prostate is sticking your finger into the back passage. And I remember that adage: if you don't stick in your finger, stick in your foot. So we can see anatomically where it is. And again, to also remember the fact that where it is that it wraps around that posterior urethra, it jaws into the bladder neck and thereby affects the outlet, affects the emptying of the bladder. If you look at it thoroughly, sometimes we'll say that the size of the prostate does not correspond to the symptom of the prostate disease. What do we mean by that? A small prostate gland that jaws into the bladder neck could cause more obstruction than a huge prostate that grows away from the bladder neck. So you may have a huge prostate, 150, even 200-gram prostate, but grows away from the bladder neck, grows away from the transverse urethra, goes away from the posterior urethra, and may not cause obstruction to compare to a 40-gram prostate that grows directly into the bladder neck. So that's why you find people saying that the size of the prostate may not correspond to the symptoms it causes. But again, just know that that's exactly what the problem is. I mentioned the function of the prostate, especially its secret and stored an alkaline fluid, almost 30% of what constitutes the seminal fluids. And also has some smooth muscles that assist us in ejaculation. So it's an extremely important organ. And again, it's also important for us to know that its functions, its diseases, its misbehavior is all regulated by the male hormone androgens. And that's why it's important both in benign disease of the prostate and even malignant disease of the prostate. Testosterone is extremely an hormone to consider with. That's why, just to make a mention there, because of the audience which you are talking to, always remember when patients comes to you and complain of something completely indifferent from prostate, talking especially erectile dysfunction, and you find out that their testosterone is low when you work them up, please, I'd like to appeal to you that whenever you want to start them on any form of testosterone replacement therapy in order to improve their libido, one of the things you must look for is assess their prostate in terms of its cancerous or non-cancerous, in terms of problem that is causing. Remember fully well that the growth of the prostate, the behavior and the misbehavior of the prostate has a relationship to the male hormone androgens, which is testosterone. So please, again, I'm appealing and putting it across now. Whenever you want to improve somebody's libido based on prescription of poviveron, make sure you assess his prostate, especially if this patient happens to be in the age range of 50 and above. Or I would say in an environment 45 and above. And you must make sure what the state of the prostate is and what is his PSA, so that one does not try to treat a treatment to to produce another disease. What is BPH? Which is what we're talking about. Precisely, it is used to call benign prostatic hypertrophy. Then we turn it to benign prostatic hyperplasia, which essentially is an increase in the cells. It's actually a pathological diagnosis. We have actually changed the word from BPH in urological literature to BPE, benign prostatic enlargement, in the sense that that is the true clinical picture. You find a prostate that is big, that has features that shows non-cancerous. So BPE or BPH, for the purpose of this discussion, is a non-cancerous growth of the prostate. Very common, usually, for middle age and above. It's the commonest tumor you find in middle age and above. And it's extremely important for us to know that it's not a life-threatening disease or a life-threatening condition, but it has a significant effect on the quality of life of most sufferers of the disease. So it's something that we must know, that it's important for us to know. I like to also mention the word hair. We should also realize that when we talk about enlarged prostate, it must also be seen from the point of view of the fact that prostate enlarges with age. So you talk about age-adjusted appropriate size of the prostate. When we talk of normal prostate size refers to the prostate with between 18 and 26 grams. 18 and 26 grams is said to be the normal prostate, but you only find that one rarely in individuals 30 years and below. So after 30 years, with a functioning testis, the prostate grows minimum about 20% or roughly about 6 grams per decade of life. So you don't expect the prostate size of a 65-year-old man to be the same of 35 or 45-year-old man. So what I'm essentially saying is that the size of the prostate also is related to age. However, you also find the size of the prostate might completely overshoot what the age you're expecting the patients to be. So an enlarged prostate does not necessarily mean a disease. It may correlate with the age of the patient, may also not presenting any symptoms. So just doing an ultrasound scan in your routine medical checkup, and they find an enlarged prostate, it's not enough to cry wow. Is that enlarged prostate appropriate with the age? 2, is that enlarged prostate causing any symptoms at all? So if it's not causing any symptoms, which we'll get to that later, and it's appropriate with the man's age, and does not show any evidence that's suggestive of cancerous characteristics, and there is no family history, all we need to do is to follow the man, to observe him. We don't scare them. A good number of our patients now are scared stiff when they hear their prostate is enlarged. A couple of years ago, when I first came to Lagos, a lot of patients keep running after me. Once they get a scan report that say they have an enlarged prostate, they will call me, Prof Jeje, I'm in trouble. I said, what is it? They said my prostate is enlarged. Do you have any problem? No. Do you have this one? No. So what I'm trying to say again, and appealing to us as the first port of call of these people, one, when we fully assess them, we allay their fears that yes, it's an aging process. It will increase with age, but as long as it doesn't have any symptoms, as long as there's no evidence of cancerous, we only need to follow them up. Just like we say, advise them to do annual checks. And when they do the annual check, they will have also annual prostate assessment. So we could see some figures there as the incidence of enlarged prostates with age ranges. And you can see that it increases gradually. By the time you are 90, 9 out of every 10 people at the age of 90 will come down with some kind of prostate problem. And in a recent study done by one of us in those, in actually a rural setting in Ido-Ekiti, Jola and a couple of us interviewed people. These are people in the community. These are people who didn't come to the hospital at all to come and complain of lower nitrite symptoms. These are just people in the community who we interviewed, assessed their prostate, did a flow rate on them, did a chart on symptom score on them, and we find out that yes, they have not come to complain in the community, but we find an incidence of almost 24% in the community. So in the community-based studies, you can find that, and this was also tally with the age that we find in the community. So it's something that we must know that it's basic thing that is common in an environment, and we should be well versed about what to do, when not to do, when to back off, and what are the things we need to do. So what are these risk factors for this problem we're talking about? What are the things that put people what I call risk factors? There's no doubt that it's, one of these factors, genetic predispositions. These things run in a family. A father who has a prostate problem will definitely pass it on to his son. So there's genetic predisposition in it. There's racial disposition. Prostate disease along the line worldwide, it seems to be common among Blacks. There are a lot of theories about it, but we still haven't been able to determine why is the incidence is more among Blacks, wherever they are, whether they're in States, whether they're in Caribbean, whether they're in Nigeria or Africa. The incidence is higher. There's a theory about probably maybe you have a higher testosterone level because of the fact that, like the whites used to believe, that we are more promiscuous than they. And we can only exhibit that level of promiscuity because of the higher level of testosterone that drives us to the female partner. But we're able to show, at least in a study by Osegbe, that our testosterone level is the same as the whites. So we have debunked that theory that we have a higher testosterone level. And some of us have also debunked that theory that yes, the Black man seems to have many more wives with those early years of Black civilization because he wants a lot of kids because he doesn't know which one is going to survive. So it's not because of high level of testosterone. It's just because of the level of healthcare that we need to see how many of our kids can survive. And then we also need them for workforce. But we also know the whites too are not as innocent as they claimed. They are more as promiscuous as we. So that issue of male hormone being a cause of racial is still not proven. But we know, epidemiological studies showed us that risk factor, apart from hereditary, race is important. Another risk factor is obesity. A good number of patients who have a high body mass index seems to also have higher prostate than their contemporary age group without that degree of mass body index. But a lot of things is being done. We don't know why. We'll probably find out one day. But we know that obesity is synonymous to huge prostate. Smoking has also been found as a risk factor, but not completely being able to show why. But we know that a good number of smokers, whether active smokers or worse still, passive smokers, seems to have some rather weak flow rate. Whether nicotine is affecting some of those endothelial cells like it does in infertility is yet to be proven. But one of that risk factor, which is extremely important, is age. Like I just mentioned, is an incidence disease that is age-related. The longer you stay, the more the chances of coming down with a prostate enlargement that will cause symptoms. You get away at 50, you get to 60, you get to 70, 70 to 80, you're likely to come down one way or the other with a prostate problem. You pray that should be benign one that you come down with rather than the malignant one. In fact, these days, if you get up to 80 and you come down with a malignant one, nobody does any prostate biopsy in an 80-year-old person, except to come down with a severe advanced disease. So going by risk factor, those ones that are unequivocally certain, age, there's no doubt about it, is a significant risk factor. Hereditary, yes, it's a significant risk factor. So when we see these patients, we must find out their parents, their father, most especially their uncles, their siblings, And then race is also one of those major risk factors. So that's just a graphic picture of what the prostate looks like in relationship to the bladder. And you could see what has done to the prostatic urethra. It's a tubular structure, but when it enlarges, it compresses that tubular structure. And that's one of the things that happens. Looking at that anatomy, is that even by simply asking some basic information from the patient history, you could answer the guess whether he's dealing with a stricture or a prostate enlargement. Most of the time, when people strain with an enlarged prostate, it does not improve the stream. In fact, sometimes it even worsens the stream. The reason being is that by straining, you increase intraprostatic pressure, and that leads to a further occlusion of that prostatic urethra. And that's why when you find out some patients, they tell you that they feel better, they pass urine better when they sit in the commode or when they sit in the water closet, as against the history you get from people who have stricture that tell, oh, when I strain, the streams is better, but somehow when the stream is better, it splits. Like one of my patients said that, oh, the streams get better. It now comes out like a shower. And so, and I smile. That's one of the things you get from somebody who has a stricture. Whereas someone who has an enlarged prostate, because the age range is almost the same, anything above 50. Straining does not improve it at all. And when it can't empty completely, what happens? You will begin to retain urine. And we all know that we all form urine on a minute-by-minute basis, as long as our kidneys are functioning well, and we're as long as the kidneys are functioning well, urine is formed per minute-by-minute basis. So if you don't empty your bladder completely, there will be retention of urine there. So looking at that, surrounding the posterior urethra, it will lead to the feeling of incomplete and then retention of urine. And then this just to another part of it, the natural history, following that compression, goes backward, we find a little bit of bladder working hard to overcome the obstruction, and then you then find hypertrophy. Then you then find the bladder wall getting tired. Tiredness leads to trabeculations. Trabeculations lead to outpouching and then diverticulum. And then you then find it expanding and suddenly affecting the upper tract. So from simple not being able to empty, to retention, to diverticulum, to idle, the ureters become dilated, back pressure into the kidney, and then impairment of renal functions occur in terms of the pathology that you can get. And remember, because it's an infravesical obstruction, that pathology on one side affects both sides. So you find that's why patients that present very late may present with impairment of renal function on both sides. So what are those things? What are those things that your patient should be able to tell you? And I put it on those slides. I think, good number of those patients that comes to you, What are those things you need to find out from them? Either directly when they come to present, or they just come for something else. So the very first one is, do you get up? How many times do you get up to pass urine at night? We should know that the normal urine frequency for a normal person with a functioning kidneys is 3 to 5 times a day. Nobody should pass urine less than 3 times a day. But you can pass urine up to 5 or even sometimes 6 times a day if you are not on any medication. At night, you may not pass urine at all, or maybe twice. So when people start passing urine more than twice at night, there'll be 3 or 4 times at night. I'm sure you all agree with me. It leads to sleep disturbance. It leads to tiredness in the morning and makes them to come over to you. Most people will complain of night frequency, but really when you talk to them, you find out that they both have both daytime frequency and as well night frequency. But it is the night frequency that bothers them most, and is the one that brings them to you and I. So when you ask them about how many times they have to wake up to pass through, that urine wakes them to pass during that night, you find out that it's both day and night. Then you find out about their urine flow. Has the urine been flowing well, or has it been slowing? Are they suddenly realizing that when they go there, their contemporary has finished and has gone, and they are still trying to pass urine? Does it come immediately, or they do have to hesitate? Or does it stop and start? Or does it start and stop? Does it dribbles? Do they wear their pants? And one peculiar thing about urine is that it has an unforgiving odor. Patients that wet themselves uncontrollably becomes outcasts. You come to the clinic and find somebody sitting alone. That patient is likely leaking urine because nobody wants to sit next to him. For those who are middle class, who are also top executive, you find out from them, are you bothered by your bladder function? These are people in which they can't postpone urination. They can't sit down for 30 minutes one night in a meeting. They're getting up to go and pass urine. If they don't immediately go there, they will leak and they wear themselves. So those are a few things that can actually throw at anybody. Many times you wake up at night, you bother about urine function. Can you actually postpone urination? Are you comfortable with urine? I mean, with these 3 short questions, a lot can be revealed by just interacting with your patient. So our own is, in what ways can we appreciate early signs? And what would be the best for me? What would be the signs that we need to pick up early enough? And what are those modalities of investigation that we should do at our various facilities to pick up some things? And what would be the best appropriate treatment that we think we should do before we refer them? I guess that is one main area in which we'll talk about, and which is our own main area of expertise should be. So what are the usual classical symptoms? I've listed the usual classical symptoms. I've mentioned them before. Basically, we have 2 sets of them. Obstructive, we call them either obstructive in which case, does the man hesitate? Does he strain? Is his stream weak? Does he have an incomplete bladder, empty? And then you have the irritated symptoms. How frequent does he pass urine? Can he postpone urination? If he's able to do that, is there any evidence of complete control, or does he have to present with urge incontinence? How many times does he wake up at night? So these are those classical symptoms: obstructive, irritative, or sometimes we put them on what we call voiding symptoms or storage symptoms, which is the current terminologies we use. So those are basically two ways in which a patient can present. But the third way in which a patient can present, apart from the ones I've listed off, is that the patient may come to you for the very first time in retention. For the very first time, inability to void, or he may have these two symptoms characterized by these two obstructive and irritative symptoms for quite a while, and then suddenly go into retention. Suddenly cannot pass urine. There are usually some precipitating factors why they cannot pass urine. It's been straining, it's been managing to pass urine, it's been waking up at night more than often. It will have been associating those ones with some form of illness or the other one. And then suddenly, he won't be able to pass urine, which may be very painful. Or sometimes he's been retaining his urine and present with chronic retention. He doesn't even know that his bladder is completely distended up to his umbilicus until you try and put him on the table to examine him, and then you now say that this man has a palpable non-tender bladder, which is a sine qua non of chronic retention. A few things always precipitate them to retention. Usually, most common thing that put them to retention is infection. A man who's been retaining his urine, who is not emptying his bladder completely, is retaining the urine, is allowing the pathogens to overgrow. With stasis, there will be infection, and with stasis, there's likely to be stone formation. So sometimes the infection now leads to edema, and the already compromised urethra becomes completely blocked. So sometimes infection push them into inability to void completely. Drugs sometimes also put them into inability to drug when they suddenly have a large volume of urine and you find what to call overcrowding. And these are the kind of things that we worry about. When patient comes to us and they claim that, oh, they are not passing adequate urine, please, before we start putting them on diuretics, or when we're managing a patient for hypertension, and we think that in addition to their various drugs, we want to give them diuretics, please let us make sure that they're not already on the verge of retention of urine. Always remember to examine the abdomen, that the man you're about to add furosemide or modiuretic or aldactone to his treatment is not already on retention of urine. Otherwise, you just push him completely down the hill. Those are a few things. Some of them collect these water pill drugs from the pharmacy, from their GPs, and things like that. Similarly, one of the things which is also important, which I want to say, is that when you're managing patients for benign prostatic enlargement, always make sure that their back passage is also very functional. One of the things that push them to retention is constipation. And if you remember that a good number of these patients are elderly people who have lazy bowel syndrome, who are prone to have constipation. Some of them pass through once or two or three, once in 3 or once a week. And when they are constipated, it can also push them into acute retention. So these are all the things that we must bear in mind when we're managing these patients. Like I said, apart from these classical symptoms, a good number of them may present with just complete obstruction. So how do we make the diagnosis of benign prostatic hyperplasia or benign prostatic enlargement in our setting? It's important to know what are the differentials. I mean, I mentioned a few of the differentials. I'll talk about urethral stricture. Usually in urethral stricture, there'll be past history of infection, untreated, past history of instrumentation to the urethra, or it may even be your past patient in which you had passed a catheter, traumatized him at that time, or trauma, pelvic injury, and things like that. And like I did mention, most patients with urethral stricture, they'll tell you that when they strain, the stream get better, but it scatters like a shower. And that gives you an idea that what they're likely dealing with is a stricture. And when you examine them, you probably be able to pick up an induration along the urethra. Remember, it could be bladder pathology, it can be bladder neck stenosis, it can be stone in the bladder, it can be bladder tumor, it can be, we're talking of benign enlargement, non-cancerous enlargement. Remember, it can also be due to cancer. And let's forget that the function of the bladder also can also be affected with nervous problem, neurogenic bladder, which we usually see with people with diabetic, that's what we call diabetic cystopathy, or we see with people with Parkinson's disease or multiple sclerosis and things like that. So those are a few of the differentials that must be in our mind, but I'm sure we should be able to, when we take a brief history, we should be able to know where we are going in these patients. So what do we do at our various levels? I mean, like I did written there, what's the aim when people come over to you? I mean, in just in any disease entity, we want to establish a diagnosis. We want to be sure of what we're dealing with so that we can ask or seek for appropriate evidence-based investigations. We want to make sure that we separate the shafts from other things. We want to assess, and depending on the degree of the patient we are dealing with, some are much more, in these days, some are much more worried more than what the necessary problem is. In fact, some patients these days, before you call Jack Robinson, will have done a CT and bring it to you, or will have done so many tests and bring it to you. So, but our aim, when we're sitting for the first time, for me, like I did mention, is to reassure them after we've taken a good history and things like that. Our aim is to establish a diagnosis and make sure that, yes, what we're dealing with is a non-cancerous benign enlargement of the prostate, and assessing the patient what we would like to offer. So a clear diagnosis is one that was an adequate history taking along the line of that mentioned, along the line to be able to identify the fact that it is an enlarged prostate and nothing more than that. But also remember that most of these patients that are going to come to us are in an age group in which they can have early carcinoma of the prostate. So that should also be in our mind at our level. We must do a focused examination. Again, like I did mention, please, it's important to examine the abdomen to make sure that the man is not already in chronic retention, or the man already have other more sinister lesion, like an enlarged liver, like a ballotable kidneys. We must examine the abdomen, extremely important in benign prostatic enlargement management. And then please always stick in your finger, your index finger. Most important. And the most important thing that should come out from when you bring out your finger is to see whether there are features in that prostate that suggest cancer. What are those features? One, the surface of the prostate must be smooth. Any form of nodularity on the surface of the prostate is a feature of cancer. The consistency of the prostate must be the consistency of the tender muscle of our hand. Remember the tender muscle. That's the consistency of the prostate. Anything beyond that, if it is hard, if it is soft, be wary. It should not be tender. It should not be painful. The rectal mucosa over it must freely mobile, must not be attached to it. And last but not the least, after we looked at that, we must feel the rectum. Because when you stick in your finger into the back passage, it's not only the prostate gland that you're assessing, you're also assessing the lower part of the colon. The greater percentage, 90% of colorectal tumor are palpable. I've had cases in which some patients are referred to us by his primary physicians without sticking his finger there. And patients were referred to us with acute retention, query prostate. But really, patient had cancer of the rectum. And you only need to stick your finger there, and then you feel that the structure, there's a mass in that rectum, completely occluding the rectum, and which actually led to the poor man having retention of urine. So please, let's remember to put our finger there. This is possible at our various GP centers. And I also agree, and I also believe that our various centers, we can pick up a few things. Just the ordinary urine dipstick. You rule out hematuria, rule out diabetes, or some evidence of infection. So that if the man is already have evidence of infection with the presence of nitrate or leukocyte esterase, we can start some antibiotics before we get cultural sensitivity. We can then order blood tests, which is important, urea and creatinine, and most especially, any Nigerian male, 45 and above, that comes to your practice with urinary tract symptoms deserve to have his PSA done. It used to be optional, but please, it can never be optional. It is a mandatory test that you ask the patient to do, no matter what it is. Let it be done. If you get the results and you don't like the results, anything above 4, then you can, it's one of those things that should be one of the things that will make you to refer the patient. An elevated PSA, a deranged renal function, urea and creatinine, must be a red flag for the patient to go forward. If you have a facility to do an ultrasound, why not? In office-based practices, a mobile ultrasound is a useful tool. There is even a point-of-care ultrasound that is attached to your laptop or to your palm top that you can actually scan the man's bladder and see whether there's anything in the bladder. I always appeal to some GPs. You can improve your skill, you can improve your care by undergoing short course in ultrasound. It adds a lot of things to your care, to to your practice. Scan the bladder, scan the kidney. What are you looking for in the bladder? Any stone there, any acoustic shadow there? What is the anatomy of the prostate? Is the prostate jutting into the bladder? What is sonographic features of the prostate itself? And what the size of the prostate? Because you need the size of the prostate will have a bearing to the treatment. And what is the man post-voiding residue? All this you can do with ultrasound. If you want to add more to your practice, I think it's an area which I think will be much of benefit to your practice and will much benefit to your care of your patients. It's not a nuclear science. It's just a skill that you can acquire, and the more you do it, the better you're perfect. So if ultrasound shows you anything, stones there, then you know this man has to go forward. PSA is elevated. 0 to 4 is the global PSA. Anything more than that, man must go forward. So with all that, we should be able now to take a decision. Just to talk about, okay, I know a few of you will have heard of symptom scores. If you love urology so much, you could collect symptom scores charts and then allow your patient to fill those charts. And then you can categorize them, whether 0 to 7, 8 to 19, or above 20. These are just objective way of assessing your patient. Not objective as such, because it's going to depend on what the patient tells you, but it's a way to categorize the patient's symptoms. And it's a way in which you can, again, calibrate your treatment, whether how far you are doing well or good. Then, what do you do? How do you manage them? What can we give them? I've listed the various treatment strategies, but I think we just talk briefly on a few of them. First one is called watchful waiting. What is my watchful waiting? Like I did mention to you, a couple of patients, no symptoms, just a routine test, a large prostate, empties bladder well, he does his symptom score 0 to 7, PSA is good, urea creatinine is good, leave him alone, just let him see you on a regular basis, called watchful waiting. Sometimes, I'll talk about that, sometimes change of lifestyle. Or can you get the 5-alpha blockers? We do know, and I'm sure you all remember, that the bladder neck, posterior urethra have adrenergic receptors, which maintain the tonicity of the bladder neck and the posterior urethra. So if you block those adrenergic receptors, it will lead to dilatation. And that's all the basis of using these alpha-adrenergic blockers, which are very effective, long-standing, daily uses, and they're very good. And there are many of them. Then the next set of drugs is the ones that lead to shrinkage of the prostate, the 5-alpha reductase inhibitors. Remember I said earlier on, the growth of the prostate relies on testosterone, most especially dihydrotestosterone, which is the active ingredient in the prostate. The testosterone is converted to dihydrotestosterone by an enzyme called alpha reductase. So if you inhibit it, you reduce the level of dihydrotestosterone, which can lead to gradual reduction in the size of the prostate, which also brings down the PSA. But because it interferes with testosterone, it also have effect on the libido and the performance of the patient. And it's only useful for glands that are big. Most glands, 40 gram, 50 gram and above. those are the kind of drugs we use it for. 5-alpha reductase inhibitor. You can combine with the alpha blockers, which we call combination therapy. Phytotherapy is just mentioned, is not recommended. And then those other things that, let me just rapidly mention a few of those drugs. But before drugs, there are a few things that I think if you're able to do, which I think is an important aspect of your care at the primary care. I did mention a lot of things that push them into retention, and I think that you try as much as possible to remember those things. What are the other things that we also need to talk about at your care, at your centers? Is when you take the history of some patients. Like I said, some of those patients need work through waiting. You can see even their lifestyle is the culprit. When a man decides to drink 1.5 liters of water before going to sleep, he's going to wake up more than twice or 3 times to empty his bladder. So their lifestyle itself. So it's necessary for us to look at their lifestyle and advise them on their lifestyle. Time voiding, empty your bladder as necessary, adequate water during the day, reduce water intake as the night goes by. If you're already diuretics, take it during the day, not at night. Avoid some of those things that irritate the bladder. If you like coffee, take decaffeinated coffee. If you like tea, take decaffeinated tea. If you like juice, mix it a lot with water. Those are things that irritate the bladder. So lifestyle alone, then advise them lots of vegetables, high fiber, so that the back passage can function well. So by just lifestyle advice, modification, water intake, reduction of caffeine, stop smoking, exercises. If he's obese, advise him to lose weight. If he has comorbidities, advise him to manage comorbidities like diabetes, hypertension. You may not need to give him anything for his low hydroxide symptoms. He'll be very grateful to you. However, if all those ones are taken care of, what are the drugs we use? I've mentioned it. I mentioned okay, just a word before I go to the drugs. The principles of medical treatment. These are a few things that you need to know that we consider sometimes before we put them on drugs. Age is important. The younger man still very sexually active, so you careful kind of drug you give him. How severe is his symptoms? How much urine is he retaining? What's the symptom score? How big is the prostate? What is PSA? What is his preference? So those are a couple of things I would consider before giving them those drugs. So what are those drugs? Short-term goals for the drugs, long-term goals. Short-term, you want to improve his urine flow rate. You want to improve his quality of life. Long-term goal, you want to make sure that you reduce the prostate and maintain his flow rate well. And then you want to reduce possibility of acute retention of urine. In the short term, you use alpha blockers, something like Flowell. When you look at the long term, you use a combination, something like Flowell Plus, which contains 5-alpha reductase inhibitor and Tamsulosin, one of the alpha blockers. So short term, you get a short-term improvement with the adrenergic blockers. Long-term improvement, usually with combination therapy, adrenergic blockers, and reductase inhibitors, and they come in a single something. So these are a few of the drugs that are available. You have the ones that are available in the market. You have some of them. They all are very efficacious and safe. The last one is Lidosin, which just come into the market. It has some kind of molecule and some activity like Tamsulosin. And those are all the things that are useful. Then I've talked about 5-alpha reductase, which is the one that shrinks. You have, basically, there are 2 types of them. One is finasteride, which is type 2, and one is dutasteride, which is both type 1 and type 2. It seems to be that dutasteride seems to reduce the conversion of testosterone to that testosterone, almost 90% reduction, whereas finasteride is about 70% reduction. So if you have to give it, a younger man, if you have to give him finasteride, we have a less effect on his sexual ability than the dutasteride. So those are kind of things you can consider at your stations. Just a word about plant phototherapy is not recommended. We don't, but I'm sure a lot of you guys will be seeing a lot of patients who bring a lot of these phytotherapies. They are bought from them by their children abroad. They come in various capsules. They are well advertised, much more than even the Flowell and the Flowell Plus. Again, because they don't go through the same scientific analysis, and they are OTCs. They tell you they do a lot of things, like those drugs they used to advertise in those days of Oluwole buses, in which they'll tell you the drug can do everything. You cure cancer, you cure this one, you cure that one. But until we find out the active ingredient of them, but it's one thing that we have to contend with. Sometimes I don't ask my patient not to take them when their children have bought them for them. All I ask them to do is take it along with my other drugs, as long as it makes you happy. So basically, to round off, it's just the two main drugs that we use. One, the alpha Jeje blockers that opens up the prostate, which I think most of you are familiar with. Various ones, Tamsulosin, Flowell is the main thing, or Dutasteride, which is the 5-alpha reductase inhibitor, which reduces the available testosterone for the glands to keep growing and causing obstruction. But most of the time, because of cases we see in our environment, we use the two combination. They come in a single capsule, and you use it. One thing I like to say is that when you put patients on these drugs, please always follow them up. Make sure that to check their urine flow, check their prostate size, and also always check their PSA, most importantly, because remember when you put them on the Dutasteride, it's not only shrink the prostate, it's also bring down the PSA. So you must check their PSA. For me, I always try to check their PSA 6 monthly and then later on annually. Prostate should remain low, but the PSA should remain low. But once the PSA start rising, then you must reevaluate them. And most of the time, you may end up biopsying that prostate. Then some patient comes into your facility with retention. You see them for the first time. It's not able to pass urine. Or you'll be managing them. You're giving them the Flowell, or giving them Flowell Plus. It still does not mean that they won't go into retention. Retention may be, like I've told you, some of those things I've told you. Sometimes it may be due to non-compliance with their drugs. Some patients feel good, they are taking the drugs, and then they're feeling good, they stop the drug, and then they go into retention, so they come to you. Some will come to you as a first presentation, inability to pass urine. So what do we do? In our GP, in our centers, acute retention of urine, they will come in acute retention of urine, or they may come in chronic retention, or they may come in acute on chronic retention. Our main care is urethral catheterization. And this is where I want to appeal to most of us. Please, 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 whenever you want to catheterize anybody, the main thing, apart from the fact that it should be a sterile procedure, remembering that you can't catheterize somebody and send him to urosepsis, so it must be a sterile procedure. Secondly, we must use xylocaine gel. I plead with you. KY gel has no basis in urethral catheterization. KY gel is just for lubrication when you want to do a PR. Please don't use KY gel lubricating a catheter for urethral catheterization. It is done. Your xylocaine gel will do two work. It will numb the place. It will also lubricate the place. You will avoid trauma, and the patient will be grateful for it. Fortunately, xylocaine gel and KY gel are the same price, so you cannot talk of price issue. So please, I beg you, and be liberal when you're catheterizing them. Use a whole 10 ml of the old xylocaine gel. You only need to bill the patient. The man is already in pain. He will pay anything you ask him to pay. So please, again, I'm saying this because we see a lot of post-traumatic, post-catheterization strictures, and usually due to the fact that there is no good lubrication when the catheter is used. So one, it should be a sterile procedure. Two, please use xylocaine gel. And three, don't use too large a prostate of a catheter. Size 18 is okay for a man, and size even 14 is okay for a woman. So 18 or at worst 20, two-way catheter. The man comes in acute tension, lubricate it very well, infuse the whole 10 mils down the urethra, wait for about 3 to 5 minutes, and then gently pull up the phallus and gently introduce your catheter. It will go in and the man will not struggle. But when we don't lubricate it with xylocaine gel, and sometimes just with a tiny drop of KY gel on the tip of the catheter and reaming into the urethra, cause so much traumatic injury. And that's why a couple of these patients will bleed. And then when bleeding finishes, healing occurs, fibrosis, spongy fibrosis, then develop stricture, which could be a problem for life. So again, I always appeal, xylocaine gel is what to use. With acute retention, passing your catheter, she got it. Empty the bladder, don't remove the catheter. Most of us would decompress and then remove the catheter. Always tell the patient, don't remove the catheter. Leave the catheter there. Try and find out what has perpetrated the retention so that we can get rid of it. So that by the time you now take out the catheter, after 2 to 3 weeks, the man may be able to void on his own. It's chronic retention, put the catheter there and let it drain continuously. Because usually most of the time, you end up with post-obstructive diuresis, which may be very difficult for you to manage, or even post-obstructive hematuria, which is also very difficult for you to manage. But again, the man comes with chronic retention, rather than run into trouble with him, his chronic retention, send him over. The acute retention, because the man is in pain, please catheterize him and then send him over. Any patient that comes with retention, relieve the pain, relieve the discomfort, and send him over. I think my saliva is almost finishing up. So I think let me keep some saliva for questions that will come. That's my last slide. And as a take-home message. Again, like I said, I'm ready for more. I'm ready for questions. I don't think it's a lecture. I think it's just a highlighting some of the things I believe is possible at the level of the primary care. And, I like to take questions or clarify some things that I've said. Once again, thank you for listening, and I hope it's been worthwhile.
Yeah, let it flow and flow well. Thank you so much, Prof. I think you actually made it flow, and it flowed very well. So, Prof would like to take questions. I think it was well delivered, and personally, I enjoyed it. So we can have questions, comments. Prof is here to take it. So if there's any question, let's have it so that you can attend to it. Questions?
Good afternoon, Prof.
Good afternoon.
This is Dr. Jibrin Yahya from Hajia Gambo Sawaba General Hospital, Zaria.
How are you?
Fine, sir. How is work, sir? That was a good presentation, Prof. We really enjoyed the lecture. It was quite interesting, sir. So I have a question, sir.
Right.
My question goes, sir. In issue of like the after doing the PSA, sir.
Yeah.
It's usually in the qualitative result, or in the qualitative, in both the qualitative and quantitative, the ones that they show, does really the level of the, what did they call it, the level of the PSA, does it really signifies, at what level does it really signifies that they are say CA? Because there was a time I was discussing with a colleague that was telling me that no matter the DC, even despite that the PSA, even if it is high, that sometimes even prostatitis can present with that. So I don't know, Prof, whether you shed more light on that.
Okay, but I guess for just to answer directly, for the
Yes,
sake
sir.
of the patient,
Yes, sir.
we should not be doing quantitative, we should be doing qualitative. We should be able to
Qualitative.
say, we should be able to say precisely what is the level
Yes.
of the PSA. Is it 4? Is it 6? Is it 10? Is it 1? Or is it anything? My take is this: if you get the exact value, once the PSA is more than 4,
Yes, sir.
just refer.
It's okay, sir.
Yeah, because it's better that way. Because if you refer me somebody, let's say a 65-year-old man with the
Yes,
PSA
sir.
5, which is just 1 above 0 to 4, let the man
Yes,
go
sir.
and see the urologist. Reason being
It's
is
okay,
that
sir.
the urologist can then take a decision whether the man needs to do an imaging study, like a transrectal ultrasound scan, or like an MRI, and things like
Yes,
that,
sir.
so that he can be sure in his mind that that 5 is not due to a sinister lesion. And he can then now say, oh, there's nothing there. Go see me in 6 months. You understand, man? Yeah, it's better
Yes,
that
sir.
way. Because the
It's
reason
okay,
is
sir.
that if you keep him, people have this tangent attitude. He will think he's
Yes.
fine. Next time you are going to see him, his PSA might have gone to 45. And even
That would be bad.
exactly. And the next,
It
before
will
you,
metastatize to other
yeah. So
areas.
once, for me, at the GP level,
Yes, sir.
PSA 0 to 4, you can manage it well.
Yes, sir.
The man does not have a big residual urine. You are fine. The man does not have doesn't have any renal impairment. You are fine. You just have some symptoms. You can start him on slow well and follow him up. And the thing to
It's okay.
also make to let people know, managing a large prostate is not like appendicitis. We just go there, remove the appendix, and that's all.
Yes, sir.
This is an aging process. And that's one thing we need to make people realize. We all pray to live long.
Amen, Prof.
So that we can reap the fruits of our labor and see our
That's true.
children. But it comes with a price. And part of the price of live long enough is prostate problem, diabetes, hypertension. So those are prices you must pay if you want to live long. So the only thing is that you tell your patient, these are things you must know. And it's not left for the patient to go and find means and ways in which you'll be able to solve his problem when those things start showing their face.
Yes, Prof. So, sir, Prof,
Yeah.
Sometimes what we usually do, I don't know whether that's because of due to what did they call it?
Wow. I can't hear him again.
Good afternoon, sir.
Good
I have a
afternoon.
question.
Go ahead, sir.
Oh, thank you very much. I'm Dr. Lawal from State Hospital.
Hello? Are you hearing me?
I enjoyed the lecture.
Sometimes at the GP, we usually send for qualitative first due to financial concept, because the qualitative is a little bit less expensive compared to the quantitative. So I don't know whether that's right.
As long as I know, I used to see it for a long time ago. But based on where you practice,
Yes.
as long as they say that quantitative, whether they say it's negative or positive, what does negative mean? It doesn't mean it's less than 4.
It doesn't mean that.
As long as they tell you that it is less than 4, fine.
So the best test to go for is the quantitative, not qualitative.
Yes, quantitative. What tells you the exact, what is the value?
It's okay, Prof.
Yeah.
Thank you.
Okay. I don't think we should, between you and I, because of the cost-benefit ratio of knowing what the PSA value is, we should not talk of costs. It's okay, sir. Because you don't know. It's just one investigation that can save somebody's life.
It's okay, Prof.
Yeah.
Thank you, sir.
Good afternoon, sir. Good afternoon, sir.
Yeah, go ahead, sir.
Once again, I'm Wale again from State Hospital. I really enjoyed the lecture. As you have said, it's like you highlight something in practical form to us. So I have just 1, 2 questions. My first one is, though I wanted to make a clarification regarding the qualitative or PSA or quantitative. I think the qualitative aspect one is the categorical one that we say yes or no, negative or positive, because there is like a mixture from the questionnaires. That is, the quantitative one is the one that is saying for 0 to 4, 6, 20, 30, 30 something. That is quantitative one. So when the answer is being given, I was a little bit confused, because what I know about qualitative is categorical to negative or positive. So I want that more clarification on that. Number 2 question is that regarding the usage of the combination therapy of alpha and the one with Dutasteride, I want to know how duration of usage of that particular combination, or even the alpha one. Is this 3 months, 6 months, or how many years before one now take further intervention on that particular patient? My question regarding the association factors other than genetic factor. People are usually saying that when a man ejaculates, I think the social media nowadays, it must be concerned. But they even hear the commissioners regarding talking about this. Like, we are online now, we are not. But social media things are saying that when you have ejaculation more than 25 ejaculation per month, you are less likely to have benign enlargement. Please, I want you to just shed few light on what I've just raised, sir. Thank you very much, sir.
Ejaculation and prostate disease. There's no that, yes, people need to ejaculate, but I'm not sure anybody can ejaculate 21 times in a month. I've also been confronted with some of my patients, but I think anybody can put anything in social media. Yeah, ejaculation and, you see, prostate disease and sexual activity. Like I did mention, there are a lot of controversies here and there. Let me give an example. The Catholic bishops are supposed to be celibacy, isn't it? But we find out that there's not been an increase in prostate disease among them. Whether they do something that we don't know is a different ballgame. But they're supposed to be unmarried, and they cannot be doing 21 ejaculation business they're talking about. But there's not been any study to show that prostate disease is more in Catholics, priests than non-Catholic priests. So that settles it. Combination therapy. What do I do? What do I advise you to? If you want to start somebody on combination therapy, like I did mention, what is the age of the patient? What is the size of the prostate? And how long do you use it for? What do I do? Before you begin, know the size of the prostate. How big is the prostate is? 6 months down the line, repeat the size, repeat the scan. What is the current size of the prostate? If you get the prostate size below 50, then you can stop. For me, I will stop the combination therapy, because we know that the Dutasteride is not useful for prostate except it's greater than 40 or 50. So for any prostate that is below 40, don't use a combination therapy for it. You just overflogged in it because it's not going to be useful. So whenever you are putting a patient on these medications, remember there should be assessment. The assessment, remember what I said, the assessment should include the PSA, because the PSA should also be going down. The moment you see that rather than PSA going down, by virtue of the drug you are giving him, the PSA is going up, then make sure that something sinister is happening in that prostate. And remember, prostate cancer, 70% of it occur in the peripheral zone. That's the posterior one that you and I can feel. Greater percentage of BPH occurs in transitional zone. That is the portion that surrounds the urethra. So you may be getting the transitional zone reduction in size, whereas, so that's why sometimes it does coexist. Patient can have an enlarged prostate and also have cancer of the prostate. They occupy different areas of the prostate. But you must always check your finger and your PSA. So if you are putting somebody on combination therapy, follow it, assessment, reduction in the size of the prostate, and then if you get to the level in which you are comfortable with, you can stop and just continue on Flowell instead of Flowell Plus. Now for first question, whether it's qualitative or quantitative, I can't even remember. The only thing I know is that go for PSA that give you values.
Okay.
It should give you values. Is it 0.01? Is it 4.5? Is it we have situation in which people will give you, for my patient, their values go to 0.001 and it rises up. So you go for those tests that will give you values. Those that does not give values have no place in modern urology. Because like I'll give you an example. Somebody comes in and say he has a PSA greater than 100. It doesn't mean anything. The only thing it means is that it's an advanced disease. But greater than 100, is it 1,000 or is it 101? 101 is greater than 100. 1,000 is greater than 100. So I want to know the exact figure. So I will know how I'm going to manage him and how I'm going to assess the response. I guess I've answered your questions.
Yes, thank you very much. I'm very grateful. Thank you, sir. Yeah.
Okay, Dr. Ju's hand is up. Dr. Ju Noham.
Okay, good evening, sir. Good evening, everyone. Good evening, Prof. Thank you for the beautiful presentation. Please, I have two questions. So, number one, okay, I work in a tertiary hospital, and then my question is this: which one is better, or is it asking for a total PSA or free PSA? Because we have both values to save patients finance. Should we be asking for both of them at the same time, or should we just use only the free PSA? Because I've heard in another lecture that a free PSA gives you a clearer picture whether the PSA value is okay or not. So I would like you to also throw light on that, whether we should go for free PSA or total PSA value. Then the second question is between abdominal ultrasound and transurethral ultrasound, which one is the best to diagnose benign prostate hyperplasia? Or which one is the best one should we use? These are the questions. Then the third question now is with regards to treating BPH symptoms and at what time to begin the treatment. If I have a young man of about 40 years with family history of prostate cancer that has PSA value above 4, at what time should I start treatment in this person? The person does not have symptoms, but the PSA value is high. Will it be advisable to start medication on such a patient, or to do the watchful waiting in this kind of a person with a positive family history of prostate cancer? Prof, these are my 3 questions. Thank you.
Okay, let me start with your last one. I think for the purpose of this discussion,
Yeah,
which you drawn towards an area of sinister lesion, which is prostate cancer.
yeah.
If you have any, for me, if you have any suspicion of somebody, and okay, there are 3 things that must be positive, that must be negative before you say you don't need to biopsy somebody. 1, PSA must be normal. 2, your rectal examination must be normal. And 3, your imaging study must be normal. If those 3 are normal, then the man does not need a biopsy. If there's any abnormality in all those 3, then the man would need a biopsy.
Okay.
I won't say that. I think when you get to a stage like that, just refer the man to a urologist. Let the urologist go and sort out his problem and take appropriate care of the patient, because he can then now warehouse the patient and follow the patient up as much as necessary. I don't think it should be something that we should be toying around with at the GP level, or even at the GOPD level in a tertiary care. But at the GOPD level, and you see a patient that you suspect that, look, PSA is beyond 4, just refer him to a urologist. Let them take a decision.
The person does not have any symptoms, but there is a family history.
He has a family history.
Yes.
He has an elevated PSA.
Yeah, but is there asymptomatic?
I've just told you what I said. 3 things must be negative. 1, PSA must be normal. 2, your rectal examination is normal. 3, your imaging study is also normal. Then the man does not need a biopsy. Okay. If your rectal examination is normal, the PSA is abnormal, then you must find out why the PSA is abnormal. That's why I said, with the family history, just send the man to a urologist to take the decision.
All right.
We must know when to back off. Now, you mentioned, your second question was transabdominal or transrectal in benign enlargement. For me, for the purpose of this talk, and for the purpose of cost-benefit ratio, and if it's just benign enlarged prostate you are looking for, a transabdominal scan, for me, should be what you should order for 2 reasons. The man with the small money he has will be able to do transabdominal and will be able to write about his kidneys. He will also tell you about his bladder. And then much more than what you're going to get from transrectal. The only main advantage transrectal has against transabdominal is the fact that it gives a better accuracy of the prostate volume, but not that too much of a variation. and also can tell you about issue of elastography and Doppler. But if we are talking about benign prostatic hyperplasia, I think when you're working them up, an abdomen pelvic ultrasound scan would suffice for your care, because it will show you both the upper tract and the lower tract. I've had a patient which I was working up for an open prostatectomy before, only to find out that he has a tumor of the kidney, which we picked up on abdomen pelvic ultrasound scan. So for what we had to remove the kidney before we now came back after a month to actually do the prostatectomy. So for the purpose of care, I think what we call a KUB, kidney, ureter, and bladder, plus prostate and post-body wrestling will be a better thing than the transrectal. Now, your first question is about the PSA kinetics.
Can we mute our mics?
We play around with PSA kinetics when we are suspecting prostate cancer. In a straightforward patient that presents with clinical symptoms of lower urinary symptoms, I think asking for a total PSA should be your first decision. I don't think you gain anything asking for free and total. However, when you ask for free and total, when we get a report of a borderline PSA, in which case, instead of PSA being between 0 and 4, a 54-year-old man, his PSA is now 9.5, and you are worried. 9.5, small prostate. Then you say, okay, let me find out before I move forward. Then we do free and total, because we know that free PSA is associated with benign prostatic enlargement, whereas complex PSA is associated with prostate cancer. So if you are looking at it globally, in the care of benign prostatic, in care of lower urinary symptoms, the very first one you should ask for is total PSA globally. But if you now get that one, and then now looking at index patient you're asking, you are looking at, then it's something else. You can then decide, because it's all PSA, it's all part of PSA kinetics. You can say, okay, I want free and total PSA. And then you can use the global PSA, what's called PSA density and things like that. But for the purpose of care for urinary symptoms or benign prostatic enlargement, the very first you should ask for is total PSA. I hope I've cleared the air. Hello? Is there anybody there?
Yes, I think you did.
Yes, we are here.
Okay.
Yes.
I hope I've cleared the air for the lady.
Yes, you did.
Yes, Prof.
Okay. Any other one?
So, Prof, I have a question. My name is Mr. Keith. I'm a pharmacist that practice in Florida.
Okay.
And I know over here in Florida, most of the BPH is handled at the primary care level.
Yeah.
I know some of our GPs are very reluctant to handle BP, even at the primary care level. So, and I know the essence of this lecture is to get them comfortable with taking care of this patient. My major concern, and I wish you have mentioned one of them, is really, when do they need to refer? Because I think it's very important that they they really know when to refer, which cases to refer in order to have optimal patient outcome. So other than the prostate cancer, what are the really important criteria? When did they really must refer those patients out and not touch them?
Okay, that's thank you for that. I mean, let's put it this way. I mean, if a patient, let me put it this way, if a patient comes in with retention of urine, whether it's acute or chronic, once the patient comes in with retention of urine and you are able to relieve his pain, which is passing a catheter, that patient must be referred. That's one. So any patient that comes to your facility with retention of urine that you need to put a catheter on, please refer them. Two, now coming to the symptoms. When the symptoms begin to have other things like bleeding, hematuria, blood is one thing that scares our people, and I'm always very happy about it because most of our people always rationalize their problem. But when they see blood, either in the urine or in the stool, they get scared and they come to you and I. So it's not that I pray that they should all see blood, though, but I think it's better for them to see blood and they come to you and I early enough so that we can solve their problem. So when there is hematuria, when there is blood, and the man say he's seen blood in his urine, whether the whole of the urine or some part of the urine, please refer. When you now, that's from the history, or the man is still in the history, the man tells you that he has, apart from his urinary symptoms, he has pain in his back. And at the time you put your finger into his back passage, you are not comfortable with the way to feel in the prostate, please refer. Once you sort his initial problem, refer. There are a lot of patients in which they complain of backache and they are given a lot of non-steroidal anti-inflammatory to relieve their pain. Only for a very long time, the man now becomes paraplegic. He can't even walk because they missed that point that he should have been referred early enough for us to pick his cancer. So when there are things like blood in his urine, pain in his back, swelling of his legs, wake up in the morning with facial puffiness, urine is not coming the way it should come, please refer. Because those are things talking about complications of the prostate disease. So when you talk to them and you could see them when you examine them that already have some problem of renal impairment, please refer. When you examine them, the prostate is not feeling good, please refer. When you then run your investigation, if you have to, you do your urinalysis in your private setup, and you see blood by your dipstick, please refer. You do the renal function test, the urea and creatinine is borderline or is going up, please don't keep them, refer them. You do your PSA, like I said, global value 0 to 4. The PSA is elevated. The man has family history. Once you solve the initial problem of reassuring him and so on, please refer. I think we'll do all that if you remember what I've said. Their presentation formats, fact, things you get to your history, things you get to your evaluation, results of our initial evaluation, and then refer. I think one of the things I was trying to develop at Luz was what I call this feedback mechanism. I hope that one day we'll be able to have a good relationship between the tertiary institutions and the primary care providers. So that once we refer, we can actually send patient back to you, which ideally should be a kind of a front and back relationship. We can look at the patient and send the patient back to you. If it's only going to be on medication, just okay, we are reviewing your patient, this is the problem, all is well, let him continue your practice and just see him as necessary. That will reduce the body that we are seeing in the tertiary center. And that will also improve the care and profitability at primary care centers. I hope I'm able to answer that question in a way.
You did. Thank you very much, because it's really, really important that we don't warehouse the patient at the primary care center when there's obvious problems, especially with cancer or stricture or retention. So yes, you exhausted my question, and I thank you very much.
Thank you.
Okay, Dr. Utibe's hand was up before initially. I don't know if she's still there. Dr. Utibe Uko. Are you still there, Dr. Utibe? Okay, I think she is off. Do we still have questions or comments so that Prof can take them? Yes, Prof, some people are also chatting if they can get your slides.
No problem. I'll send it to you now. I'll send it to you, then you can send it to them.
Is that right, sir?
Or, okay, you can't. You didn't record it from your end? Did you record it from your end? Victor?
Yes, it is recorded.
Everything is recorded now. You can send it from them now. It's not. Don't worry, I won't charge you for copyright.
Is that right, sir?
I won't charge you for copyright. It's information, and it's better you allow information to freely flow than hoarding it and take it to your grave.
You're right, sir.
Yeah.
So I don't know if there are still questions so that we can take, but in the absence of any other question, maybe we can just wrap it up here. Questions? Okay, in the absence of any other question, Prof, on behalf of Superior Pharmaceuticals, we would like to say a very big thank you for the lecture. It was well delivered. Like you rightly put it, let it flow and flow well. I think you actually made it flow well. We appreciate you and want to say a very special thank you to you. Thank you so much, sir. We really appreciate it.
My pleasure. I mean, we have to continue to do our best. Since I've not Japa, and the audience I'm talking to, I'm pleading with them that they should not Japa. We can Japa within Nigeria.
I think you're right, sir.
So no problem. You can send it to as many as people that would like to. And then if there's any, you can give them my email or my number if anybody wants any further clarification. If they have any patient that they want advice on, it's free. I'll give that one freely.
Okay,
yeah. Feel free to contact me in any of your patients. I mean, they're Nigerians like you and I. Let them benefit from our knowledge and skill. Feel free. Send me a text. Send me a mail. My number is on WhatsApp. You can get that one. Thank you, everybody.
All right. Thank you so much, sir. We appreciate you, sir.
It's a pleasure.
Thank you, Prof.
Thank you, sir.
Okay, my dear. Take care. Yeah.
Very much, Prof.
Yeah, thank you. Thank you for that. Yeah.
Yeah, I also want to thank all the people that participated in the program. We'll say a very special thank you to you all.
You're welcome.
You're welcome.
Thank you.
Thank you for organizing such a meeting.
Thank you very much.
Thank you.
Thank you.
You're welcome.
Thank you. It was enlightening.
Thank you.
You're welcome.